All right, we'll get started. Thanks everyone for taking time out of your busy schedules to join the AHPBA webinar. I'm James Park, Chair of the AHPBA Surgical Innovation Committee and System Chief of Surgical Oncology at Mount Sinai Health, and I'll be moderating this session. This is the third webinar out of a four-part series through the AHPBA, and it is entitled Artificial Intelligence and the Future of Technology for HPB Surgery. First, I'd like to thank Professor Mariano Jimenez, our current president of the AHPBA, and members of the SIC for future-facing vision, which has resulted in the conception of today's webinar. And especially to Dr. Jimenez, because it's midnight where he is in Strasbourg, France, so with an early case tomorrow morning. So thank you very much. Second, we all know that none of our concepts will be realized without the meticulous organization and bold operationalization by Jill Wilhite and Barbara Weber. So thank you very much. We have a fantastic lineup of speakers today, but before I introduce the first speaker, I'd like to mention a few housekeeping points. The webinar is scheduled for 90 minutes and is being recorded. Each of the three speakers will have approximately 15 to 20 minutes, leaving ample time for a robust panel discussion at the conclusion of the three talks. So please make note of your questions and discussion topics in the chat. Please mute your microphone when not speaking. All right, let's get started. Our first speaker, Dr. Theodore Grantcharov, is Professor of Surgery at Stanford University and Associate Chief Quality Officer for Innovation and Safety at Stanford Healthcare. He completed surgical training at the University of Copenhagen and a doctoral degree at the University of Aarhus in Denmark, and was Professor of Surgery at the University of Toronto and Keenan Chair of Surgery at St. Michael's Hospital in Toronto prior to joining Stanford. Dr. Grantcharov's clinical interest is in minimally invasive surgery, and he is an internationally renowned leader in the field of surgical performance with more than 220 peer-reviewed publications on its impact on clinical outcomes. He holds several patents and is founding CEO of Surgical Safety Technologies that has commercialized the OR Black Box platform, which aims to transform the safety culture in the high-risk operating theater environment. Theodore, it's an absolute pleasure to have you join us today. Looking forward to a great talk. Take it away.
Thank you so much, Jim, and I really appreciate it's an honor to join this webinar and share some of my experience. I want to apologize. I'm in the OR today. It's 3 p.m. In California, so I may be called at some point for my next case, but I'll try to stay up to the end and participate in the discussion. As Jim mentioned, I am founder of Surgical Safety Technologies, which is an academic startup that commercializes the OR Black Box platform. So throughout the talk today, I will show some of the products which are part of the OR Black Box, but we'll focus primarily on evidence surrounding their application and impact. We're talking about AI and data science. The fundamental concept here is replacing surgery or surgical craft with science. And as one of my mentors used to say is, or says is, we will see less and less art in surgery and more math. And there is a purpose for that. There is a significant variability in outcomes, and also significant variability in performance, and significant variability in system design. And in order to see some impact on a positive outcome, positive impact on outcomes, we will need to address the sources of the variability. And there are a lot of, I'm sure many of you have seen the numerous publications suggesting how dangerous surgery is and how many things we can do to make it safer. Many of these publications, the methodology can be questioned, but there is no doubt that there are so many things that we can and we should do better for our patients and also for our profession. This is one of my favorite quotes from the James Clear book, Atomic Habits. It always, every year, reminds me when we talk about our goals, professional goals, but also corporate goals. As our institutions declare every year their goal to reach zero patient harm and significantly reduce surgical site infections and anastomotic leaks and so on. And that's, of course, these are great goals, but without introducing system measures to reduce variability and to have a much better understanding of the processes and deviation in processes that lead to these adverse outcomes, we will never be able to achieve these goals. And I think data science and AI can play a very significant role in this process. The problem in the operating room, and I know we're focusing today on the impact in HPB surgery or in surgery in general. The problem with introducing data science is that we've had a lot of challenges with acquiring high quality data in the operating room. And to date, I would argue that it's still one of the least understood environments in healthcare. And this is one of the reasons why the motivating factors for us to introduce this data acquisition platform that we call Operating Room Black Box, which introduces sources for unstructured data such as audiovisual data. It incorporates existing data sources from electronic health record and engineering systems in the hospital. It also can integrate to a number of new technologies such as wearable devices that can help us quantify attention, fatigue, wireless EEG of the brain to understand activations during critical steps of the procedure and so on. So a limited number of factors that we can bring together is perfectly synchronized and then turn this data into information that can help us improve. It's important to highlight that this is not, and one of the reasons why this approach was successful in other high-risk industries such as aviation and nuclear oil industry is the process there was confidential and non-punitive, and this was one of our main challenges and one of the main focus of our work in the early days when we were introducing this platform. And one of the first AI algorithms that we introduced was algorithm to irreversibly de-identify individuals and data that we acquire. As you can imagine, all these hundreds of thousands of data parameters per operating room per day allow us to quantify a lot of factors. And the deeper we try to understand the relationship between these factors and the relationship of these factors with outcomes, the more we realized how complex this process is. It's not enough to study technical skills and non-technical skills. We need to understand a lot of other hidden dependencies here that could impact performance and clinical outcomes if we want a meaningful impact. And we were very clear from the early days that in order to see some impact, we needed to start with asking important questions that matter to us as clinicians who are not trying to develop technology for technology's sake or AI algorithms for the sake of another peer-reviewed publication. We wanted to understand, can we use this to objectively assess performance and objectively assess processes? Can we use it to enhance education? Can we use it to improve safety culture? Can this technology make our lives better and easier when we are in the operating room? Obviously, we needed to answer an important question whether we could reduce costs. And the billion-dollar question here is, can we use this to improve clinical outcomes? I will give 3 examples. One of them is the use of data or data science to enhance performance and to use that to improve performance and with performance improve outcomes. And there is a tremendous need for disruption of the educational process. I'm sure those of you who are involved with resident education will recognize that not much has changed in the past 20, 30 plus years in the domain of surgical education. We still evaluate our residents and fellows and ourselves using subjective methods. We still provide meaningless feedback. We still don't have well-established performance standards of what's acceptable and what non-acceptable. And still a lot of the fundamental processes in the creation or the process of becoming a surgeon, selection, promotion, and certification are done based on traditions and dogmas. And this was one of the reasons why we felt that introducing video-based assessment and video in general is a very powerful tool that can significantly impact this process. There are many examples of using video as an educational tool, and the question here is how can we make it scalable and how can we deliver it at a low cost so that many people around the world can access it. So in order to do that, we've done a lot of work with capturing not only laparoscopic robotic but also open videos for open surgical procedures. We've done a lot to streamline this process so that it is automatically downloaded. It can provide, the system can provide several layers of AI-driven analytics around performance, around intraoperative adverse events, around procedure segmentation, and allow of the individuals to share their performance and seek feedback from their peers. And why does it matter? It matters because our performance impacts clinical outcomes. We know all the work that Birkmeyer did, or the initial work that Birkmeyer did, and suggested that performance during bariatric surgery is significantly is an independent predictor for clinical outcomes. We've shown that in a number of other surgical procedures. This multi-center trial that we did in laparoscopic gastrectomy for cancer across 3 centers in Toronto, which showed that surgical performance was an independent predictor of post-operative outcomes. And in order to create this circle for improvement, we need this scalable assessment of our clinical performance that can't be done by human, and where AI will play an increasing role. The circle of improvement starts with assessment of our performance in clinical environment. Then through rigorous measurement, we can identify opportunities for improvement, and then we can use that in a number of models, whether it could be simulation or other educational tools. This is an example of applying this data for deliberate practice initiatives. This is a randomized trial that we did in Toronto a few years ago, showing that individuals who go through deliberate practice significantly outperform their peers. Similarly, using the concept of coaching, we've shown that individuals, this is again a randomized trial done a few years ago, it showed that through better coaching, we can not only improve performance, but we can reduce intraoperative adverse events. The second example of the power of data science is in quality and safety. And we all know that we've used M&Ms as a tool for it is one of the foundational tools for quality improvement in surgery. This is a study that we did in Toronto, which showed that surgeons don't remember at the end of the case whether there were any adverse events or something that deviated from the perfect course. And a week later, the majority of the adverse events that happened were incorrectly classified. So basically, nobody remembered what happened in the operating room a week earlier, which shows that in order to make an impact, we need objective measurement and unbiased processes to measure our performance. This example is one of the great examples, and some great success stories was around introduction of surgical safety checklist. We do that now with a OR black box using various AI methodologies to quantify compliance, engagement, and quality of the surgical safety checklist. And this is an example, a trial that was published a little over a month ago out of UT Southwestern in Texas, showing that through this data-driven quality improvement, they were able to monitor their performance around surgical safety checklists and other standard operating procedures, and they showed dramatic improvement with when it was driven by data. And with that, they showed also statistically significant impact on clinical outcomes, morbidity, mortality, and elimination of never events, which was similar to the initial work that was demonstrated by Atul Gawande in the Multi-Center trial. We use this data from every single procedure now to identify outliers or procedures of interest. We can use it to identify what proportion of the procedures were associated with intraoperative adverse event, and by reviewing those, we can extract important process data or measurement of processes that could identify risks or safety threats and resilience supports that we can address as a system. And we've had a lot of success stories across multiple institutions where we have collaborated to roll this initiative. We've shown that we can power much more meaningful discussion during morbidity and mortality meetings. We can identify trends and mitigate risks before they've resulted in adverse outcomes. And I think we'll see, as we are running this now in real time, we'll be able to impact the care of the patient, not only the patient who will be in the operating room tomorrow, but also the patient who is in the operating room today. The last example I'll do, I know the time is running fast, is going to be the use of data science to enhance clinical operations. And one of the major frustrations for us as clinicians or frontline clinicians is inefficiency in scheduling and inefficiency in the way we run ORs. It's not unusual in large academic centers to experience 1.5, sometimes 2 hours turnover times. And some days where we believe that we can go home at 3 o'clock, we know that most likely that is unrealistic. So we've deployed a real-time computer vision model that powers this model that we call room state. And it allows us to not only predict how our day will look like compared to what was scheduled. It allows us to do much more accurate scheduling. It allows us to plan our day and communicate much better in the operating room. And some initial data that from the first, we rolled it out a few months ago. We've shown that we can reduce turnover time, we can reduce overtime, and we can also significantly improve staff satisfaction. We're looking forward to launching this in collaboration with a few of our partners and measure the impact on wellness, clinical wellness. This is an example of how this data can be used to produce much more accurate scheduling. To the left, scheduling done by a human, and to the right, scheduling done by a machine that takes into account not only historic means and medians, but also patient factors, disease factors, and factors related not only to the surgeon, but also to the team. I'll stop here. Thank you again for inviting me, Jim, and I hope I can still to the end to participate in the discussion.
Yeah, thanks so much, Theodore. We'll move on to the next speaker, but please stick around if you can. I'm sure there are lots of questions for you. Thanks for the fantastic talk. Our second speaker, Anthony Jark, is Vice President of Digital Products and Machine Learning Insights at Intuitive Surgical. He obtained his degree in mechanical engineering at Cornell, studying the control moment gyroscope actuated robotic arm, then completed his PhD in biomedical engineering at Northwestern University, focusing on muscle design optimization using computer simulation and performing surgical procedures to electrically restore paralyzed hind limbs of rats. He was also on the Northwestern University Triathlon Club, demonstrating his focus and tenacity. He joined Intuitive Surgical in 2011 and has risen through the ranks to his current position as Vice President of Digital Products and Machine Learning Insights, where he oversees development of innovative digital technologies to improve surgical workflow and surgeon performance in robotic-assisted surgery using advanced data analytics and intelligent machine learning systems. Tony, thank you so much for making time to speak to us today from, I think, Peach Corners, Georgia. Looking forward to your talk. Take it away.
Thank you very much, Dr. Park, and the rest of the organizers for the opportunity to present today and for that kind introduction. Do we see the right screen here?
We see a presenter view, if you could do. Yes, that's great.
Perfect. Awesome. Well, difficult to follow Theodore as he delivers amazing presentations each time, but what I like to do is narrow in the focus within robotic surgery and give a bit of a perspective on how we're staging together an ecosystem and an integrated set of technologies that deliver data back to the fingertips of surgeons to hopefully improve efficiency and safety. Similar to what you heard before, it really matters in terms of your end goal and the focus of your technology. And we focus a lot on the quintuple aim, the ability to deliver better outcomes with the total ecosystem, the ability for a better patient experience, better care team experience, lower total cost of care, and improved patient access. And these are hard problems, very, very difficult problems, not only to measure, but to tackle with a set of solutions. But when stitched together, I think there's amazing potential. One of the areas that we focus on is surgery and the ability to better understand what leads to a higher quality surgical episode. Traditionally, we have preoperative data about the patient, potentially about the surgeon and his or her experience, and then we have postoperative data around what might be some of the outcomes of that patient, and we use this information for a variety of purposes to understand performance, quality, efficiencies within a hospital or within a surgical team. With the introduction of some of the enabling capabilities in robotics, we're able to measure a whole lot more things about the surgical episode. We can measure various data streams that paint a more complete picture, and we can then factor this data into some of those models and some of the technologies that we can deliver back to our care team. One area that I'll focus on for this presentation are ways that we can extract objective performance indicators or objective insights or metrics from Da Vinci system data, but also various analyses leveraging AI or machine learning. I mentioned it a bit earlier, but at the core, we have a robotic system and a set of computers and sensors, but surrounding that, we have a variety of technologies that we want to stitch together to be able to best empower our surgeons and our care teams, from 3D modeling and visualization of preoperative images to MyIntuitive, which stores historical case portfolios and prospective objective insights, to virtual reality simulation with a variety of exercises targeting technical skills, to augmented reality or mixed reality technologies, to telecollaboration, to be able to share knowledge between different individuals, and then some very enabling AI and ML capabilities that find their way in perioperatively, but then over time intraoperatively to prevent potentially inefficiencies or things from happening beyond just recommending after surgery. But to do this, we've been working with various surgical societies, various other companies, and many of our surgeon researchers to be able to establish a new language for this data. And so if we look at some of the ways we can describe surgery, we can start with traditional measures of operative time or skin-to-skin time, but then we're layering in more and more specifics around how much time and during what periods of time individuals are leveraging various surgeon consoles on a robotic platform, when they're actively controlling the instruments, how they trade off between those instruments, and ultimately what types of activities are happening within the surgical episode performed by various surgeons. This taxonomy is critical so that we can compare apples to apples and develop a peer-reviewed set of evidence to back the technologies we build and to ensure that they're meaningful. With this ontology, we can take various data streams, such as video data, look at it across the entire case level. We can break it down into steps within a given procedure, such as splenic flexure mobilization or anastomosis. We can also look at phases, surgical phases, which are agnostic to procedure type and generalize more readily, like exposure, dissection, transection, et cetera. We then layer on some of these objective performance indicators within these various clinical context windows, things from events data like hand workspace volumes for ergonomic positioning to energy or cautery use during particular steps of surgery, to instrument exchanges that might speak to general OR efficiency, to how you visualize your environment with camera control. On the kinematic side, we can also measure the endpoint position of your tool and the workspace volume you use it to be able to work on particular anatomy, the efficiency by which you move or the hesitation associated with movements. Really excitingly, I'll show you some examples of how we can measure forces on the back of Da Vinci 5, and then also things like wrist articulation, restoring that minimally invasively, similar to open surgery. Now, one question we want to ask and we want to be confident on is, do these objective performance indicators actually matter? Do we have early signals to suggest that they're important in terms of some of the most important predictive analytics? And here's just one example, but it's been replicated by various research teams within their own procedure specialty and then also across hospital systems. But if we include objective performance indicators alongside those clinical factors preoperatively that I mentioned before, as well as surgeon experience, we're able to better predict postoperative outcomes. This is an example within hysterectomy, where the light-colored blue bars are objective performance indicators from the surgery. The gray bars are clinical factors, and the dark blue bar is surgeon experience. And you can see some of the top predictors in our model end up being the information from the surgical episode, which is quite exciting as an early and potentially actionable signal to be able to improve surgery. How do we surface this back to surgeons? We have an app called MyIntuitive. Maybe some use this. We've historically been able to present the operations of a practice through case reports, which manages the case history and provides quick insights on which instruments are being used in various durations, along with a procedure readout of console utilization and some of the instrument exchanges that you see in the bottom left here. We've extended that with some new capabilities where we've layered in video and the ability to segment video into clinical activities, as well as an extension of objective performance indicators or objective metrics to better understand surgical performance, such as the force levels that are used during surgery, or the way that you move your hands to be able to maintain ergonomic position. We're just getting started with understanding some of the value at scale with some of these objective performance indicators coupled to video. And so what I'd like to do is walk through how we go about solving some of those problems at Intuitive and with many of our collaborators. And it really comes down to answering three particular questions. The first is knowing what you're doing during surgery. So that can include things like procedure recognition, which procedure is happening, the underlying surgical activities of phase, step, or gesture, detecting errors, or providing advanced data visualizations that give you some visibility into the volumes you're working on. Once you know what you're doing, you might want to know what you're looking at. And so things like out-of-body removal for privacy preservation to anatomy recognition, scene recognition, or surgical milestones can constitute things around what you're looking at. And then we want to know what is good. So can we bring and layer in these objective performance indicators? Can we support outcomes prediction? Can we drive actionable recommendations to be able to become more efficient or a higher performing surgeon? And can we also support with other advanced data visualizations that allow for root causing around what is good? And so if I walk through each one of these, I'd like to kind of talk about a few examples. Here we have a set of procedure bars and colors that talk about surgical phases. You can look at them across different procedures and then dive into any one surgical phase to be able to review that surgical video. So it supports some of the search activities. You can pull up the instrumentations. You can look at force profiles. Those white lines are the actual instrument forces to the tissue that are provided during surgery on Da Vinci 5. On the right-hand side, you can see some objective metrics. You can also jump to different clinical segments to be able to further interrogate what might have happened and what are some of the corresponding objective efficiencies associated with it. Others have published extensively on these data visualizations, like you just saw with 3D trajectory visualizations, or noodle plots, as I call them, that tell you, give you a window into some of your movement efficiencies. So super exciting time to be able to surface and make very actionable this data shortly after the surgical episode. If we transition over into knowing what you're looking at, you can start recognizing key structures and anatomy in the image and jumping to those moments during surgery. So here we're identifying various aspects of the critical view safety within a cholecystectomy, so that you can determine not only when did the critical view safety happen in a surgery, but did you achieve the 3 criteria as published in some of the society guidelines around successful surgical view safety. And these sorts of surgical milestones extend across procedure types and across specialties in incredibly exciting ways to be able to layer on objective insights. And then lastly, knowing what is good. And I'm sharing some information here around the utilization of force feedback within Da Vinci 5 procedures. So you can see here, for this particular example, when force feedback is turned off, meaning surgeons aren't feeling the forces at their hand controllers, they actually end up exerting higher forces during surgery than when force feedback is turned on, thereby with haptic feedback, performing gentler surgery. And what they can do is they can actually dive into further deconstruct what might be happening within those force profiles that constitute either higher or lower forces and some of the trends within surgery. This is particularly exciting given some of the early Halstedian principles around gentler surgery, and now our ability to finally measure some of these capabilities and empower the surgical community to interrogate the usefulness of this information. Now, one of the areas that I'm particularly passionate about, and my trajectory at Intuitive has been heavily rooted in medical research and the surgical data science field, is how do we empower the community to interrogate and study objective metrics, the utilization of some of these new digital tools as we drive toward improved efficiencies and outcomes. And here's an example of how this literature has grown significantly over the last several years across different surgical specialties as rows and across different types of research papers, such as surgical skill and education, operative workflow, clinical outcomes, things around simulation, methods around data science and AI, reviews, et cetera. And we've seen a tremendous amount of growth across different specialties and hope that there might be additional expansions to this as well. So would like to end with maybe a bit of a call to action. We've got, hopefully I've convinced you that we have this immense opportunity to describe surgery with data. We have new sensors and new signals and applications that are enabling surgeons and institutions to understand what's happening in surgery a whole lot better. We have an opportunity to contribute to this emerging field of surgical AI and data science. There's a large number of surgeons that are leveraging these technologies and a growing number of surgeon scientists that are exploring ways by which they can make sense of this data and drive improvements within their programs. And then finally, there's this amazing opportunity to establish a virtuous cycle of evidence. With many procedures happening across many systems, we have an opportunity to study that, measure the impact, and then propagate best practices out while then studying further impact as new technologies are introduced. So I hope many of you are already involved. If not, I hope you take the opportunity to work with each other, with societies, and with industry to tackle this really exciting problem. Thank you.
Thanks, Tony, for that very stimulating talk, and I'm sure you'll find many collaborators on this line. Thanks again. Last but not least, our third and final speaker, Dr. Xiaoying Wang, is professor of surgery in the Department of Liver Surgery at Zhongshan Hospital, Fudan University in Shanghai, which is one of the largest liver cancer centers in China. Dr. Wang completed his general surgery training at Southeast University Medical College, received his PhD from Fudan University Medical College, and completed fellowship in MIS and robotic surgery at the University of Illinois at Chicago. Dr. Wang's clinical interests are in minimally invasive liver surgery and liver transplantation. He performs over 400 MIS liver resections annually, and he was the first surgeon in China to complete robotic live donor hepatectomy, robotic ALPS procedure, robotic thoracoscopic hepatectomy, and robotic concurrent resection of rectal cancer with liver and lung metastases. He developed a technique of portal venous injection of indocyanine green for MIS anatomic segmentectomy, and a fluorescence-based sentinel lymph node biopsy technique for intrahepatic cholangiocarcinoma. But what's most impressive to me is his involvement in some very exciting research focused on the use of deep learning networks to develop frameworks of liver vascular segmentation and prediction of microvascular invasion in hepatocellular carcinoma. Xiaoying, thank you so much for joining us on this webinar from Shanghai. I can't wait to hear your talk whenever you're ready.
Yeah. Okay. Thank you for the kind invitation, and it's a great honor for me to join this interesting topic. And I will share my slide first. Can you see the slide?
Yes.
Okay. So according to the schedule, my topic is innovation, AR, and technology in HVP surgery. But it's too big for me. I will focus on our work, which related to this topic. I come from Zhongshan Hospital, Fudan University. We have 215 beds for liver surgery, perform 7,000 liver resection per year. So it's the largest liver cancer center in China. And today I will focus in three topics. The one is the innovation in the fluorescence-guided liver surgery. The other is the AR in stratification and the treatment of HCC patients. And the third is the using mixed and augmented reality in liver surgery. So as we know, anatomic resection was proposed by Professor Markuch, which means systemic removal of hepatic segments confined by tumor-bearing portal tributaries. It could improve the oncological results for HCC and limits complications. So the traditional way is to use the blue dye injection, but it's not works very well in laparoscopic approach, and it will wash out very quickly. The other technique is a glissoniopatic approach, which can use for open and laparoscopic, but it is impossible to identify intersegmental plane in the area without hepatic vein. So the Japanese surgeons started to use the ICG in 2008 in open approach. It can provide both clear demarcation line on the surface and intersegmental plane in the deep side of the liver. But in the laparoscopic approach, there is some difficulties, especially for the posterior and the superior segments, because the Glissonia approach is technique difficult. So we developed ICG fluorescence staining by multimodality image guide, such as laparoscopic ultrasound and the preoperative 3D simulation guide portal vein puncture technique. Here is the example. It is the tumor located in the segment 8. You can see there is 4 branches for the segment 8. So during the operation, we use the BR ultrasound to check the tumor and also find the portal vein to the segment 8, and use the BR ultrasound guide puncture technique. You can see the PTCT needle injecting to the portal vein, and the ICG was introduced. And after inject a small amount of ICG, you can see the portal territory was fluorescence. So we can inject one by one the small branch to segment 8 and make the whole segment 8 fluorescence. And then we transect the liver parenchyma according to the fluorescence boundary. Here is the boundary between segment 8 and the segment 7. This is the boundary between segment 8 and the segment 4. So you can see with the ICG fluorescence guidance, we can easily identify the intersegmented plane between segment 8 and the segment 4. And with the CUSA, we can expose the intersegment vein, which is the landmark of the portal territory. So this already became our routine work because for the HCC, it's tend to spread through the portal vein. So we try to remove all the portal vein territory. Then we got to the glycerol pedicle to segment 8. Then you can see some drainage in the hepatic vein. Actually, this is also the landmark between segment 5 and the segment 8. So we just follow the fluorescence. So all the anatomic structure was exposed naturally. And you can see if we go along the right plane, there is less bleeding. Yeah, this is also the intersegmental vein between segment 7 and segment 8. So this is another drainage vein to right hepatic vein. Also, this is a small branch to the middle hepatic vein. Then we expose the IVC and follow the fluorescence boundary. Actually, you can see it's easy to identify which is the drainage vein, which is the intersegmental vein. For the intersegment vein, we have to preserve it. So with this ICG, we can easily transect to the liver. Okay, so this is the segment 8 resection, which is the most difficult segment resection in laparoscopic liver resection. And we standardized all the laparoscopic anatomic segmentectomy, which published in NNF surgery. And sometimes tumor not located in the center of the segment. So we have to do multi-subsegmentectomy. It's like a jigsaw game. For example, for this case, there is 4 branches fitted to the tumor, 2 from segment posterior branch. The other 2 is from the anterior branch. So we have to stand 4 subsegments and remove all the 4 subsegments. During the operation, it's pretty much similar as the last case we have shown, we try to find the tumor and the Potovin to feed the tumor area. Then use B-ultrasound intraoperative ultrasound guide to puncture the Potovin, inject the ICG. So you can see this is the two subsegments of the segment 7. There you can see segment 7 fluorescence. And injected other subsegments of the segment 8. Okay, then we got to the 4 subsegments fluorescence. The trash section is quite similar to the first case, so I will skip it. And I will introduce the lymph node mapping of the ICC, intrahepatic cholangiocarcinoma by ICG fluorescence. As we know, for intrahepatic cholangiocarcinoma, lymph node resection is recommended. However, there is no clear definition of regional lymph node. This is the AJCC definition. It's just divided the drainage pattern from the left or from the right liver, but it's not so specific for all the case. And extended lymph node dissection just showed similar results to those lymph node sampling groups. So it's still controversial. Could we use the same concepts of the sentinel lymph node as the gastric or breast cancer? It could provide precise lymph node status intraoperatively and avoid an unnecessary lymph node resection. So let's see the lymphatic tissue in the liver. We try to inject the ICG in the subcapsule of the liver, but it doesn't work well. Then we inject ICG into the glycerol pedicle, which you can see the lymphatic vessels go along with the hepatic artery and Potovin. So let me show the example. This is the ICC in the left lobe. We just yes, we use the same technique, the puncture technique, as the Potovin, but to just inject the ICG into the glycerol shells, not in the Potovin or hepatic artery. After inject a small amount of ICG, you can see the ICG going down through the lymphatic channel. And we can observe the dynamic ICG movement. So you can see here is the segment 1. Also, not segment 1, the station 1, and then also station 8, station 9, which we dissected the lymphatic tissue according to the fluorescence. So you can see with the ICG, we can easily identify which is the fat tissue, which is the pancreas, which is the hepatic artery. So we just try to follow those fluorescence to remove all the tissues with the fluorescence. So we think we can skip a little bit quickly. And you can see here is the lymphatic tissue between the left gastric vein and the gastric artery. If you don't have the fluorescence guide, you will miss this part. So with the ICG, we can clearly identify the lymphatic tissues and do very precise lymph node resection. here we finish the lymph node resection. And here is another example at with the accumulation, the experience, we understand the sentinel, the lymph node, it varies according to the ICC, the location. For the ICC in segment 2, you can see the station 1 lymph node first, the fluorescence, but for ICC in this segment 3, station 12A, station 8, and station 9 fluorescence. However, 12B is negative. And for ICC in segment 4, it's show the different patterns. 12A, 12A fluorescence, 12B also fluorescence. And for ICC in segment 5, you can see 12B, 30 fluorescence, and also station 8 fluorescence. Station ICC in segment 6, you can see 12B fluorescence. However, 12A and 8 station is negative. And ICC in segment 7, you can see 12P and 12P fluorescence. 8 station is negative. So we understand sentinel lymph node can be clearly identified by ICG fluorescence, and sentinel lymph node varies according to the site of the tumor. So now we switch to the lymph node resection from regional lymph node resection to sentinel lymph node resection. And ICG works very good. You can see works good for the tumor detection and the portal vein staining, and also for the lymph node resection, but it's not tumor specific. So we design and the screening of the tumor specific fluorescence probe, which now we find 2 good tumor specific fluorescence probe, which now go into the phase 1 clinical trial. And we try to use the AR to stratify and treat of the HCC. This is a BCLC station system, which is widely used in Europe and the United States. And in China, we also have the guideline for HCC treatment and staging. But the patient is varies. For the earlier HCC, some cases with the microvascular invasion, which has a very high recurrence rate. But for some advanced HCC, it can get a very good response for the downstage or conversion treatment. So how to identify or stratify those patients? We try to use the AR to predict the microvascular invasion in HCC based on the preoperative, the MR. This is one of my fellows' work. You can see the deep learning model with the MRA image and also clinical characters. It shows very good AUC, which can achieve the 1.934, which is very good. And also the works show the liver resection with wider resection margin was associated with better OS and recurrence-free survival in deep learning predicted microvascular invasion patients. And for advanced HCC, we use AR to predict the response rate for the conversion treatment. This is also my colleagues' work. We use the AR to predict the targeted and the immunotherapy for advanced HCC. You can see the AUC also quite good in the training, both training and the validation cohort. And also you can see this is multi-center data in the the AR predict positive case, the object responsible rate achieves almost 92%, which is very high. So we can use this technique to stratify the patients and identify what kind of patient or which patient can benefit from the conversion therapy. And also we use the AR technique in the pathology images to predict the progresses of the patients. For those with the high recurrence rates patients, we use the adjuvant therapy for those patients. And also we try to use some mixed reality or augmented reality in liver surgery. Here we use the mixed reality for the trocar placement in the laparoscopic liver resection. And you can see with these HoloLens, we can match the preoperative 3D with the patient, and which help to locate the liver and the tumor. Also, you can design the very good portal placement to get the access to the tumor. Those works very good for the young surgeon and also for the teaching, because with this mixed reality, it's easy to show where is the tumor and the liver for the new hands. And also we can use this technique in the liver resection. So for example, we can use this mixed reality to show the anatomical structure of the liver, which can get the better understanding of the ultrasound image, and also get the better understanding of the anatomical structure when we do the parenchyma transection. So it's really good for the new hands and the young surgeon. And we also developed some augmented reality in liver resection, but it's just at the beginning. It's hard to get a very good restriction. I mean, the accuracy of the rejection is still need to improve, because the liver is no rigid and it's always deformed when you do the operation. If you mobilize liver or retract the liver, there is difficult. But we try to use some AR technique to solve this problem, but still work on it. And the future perspective, we think the tumor visualization in minimally invasive surgery is very interesting, especially for the tumor-specific fluorescence probe and the multi-wavelength fluorescence endoscope. And also AI will help precise stratify of the cancer patients, and more VR mixed reality or AR used in surgery. Thank you for your attention.
Xiaoying, that was a fantastic talk. Thanks very much. Unfortunately, Theodore had to leave because his case started, but please go ahead. And I'm not sure, Barbara, if the attendees can unmute themselves. If not, if you could leave your question on the chat. And while that's happening, I can start with some questions. Tony, that was a fantastic talk, and you know, I'm looking forward to seeing and using a lot of these OPIs with the new system. I guess one question that I had was how you marry the two data sets together, the kinematic information versus what's being obtained visually. So one could imagine a situation where the kinematic movement of the needle, as an example, in the needle driving by the surgeon could be perfect. But if you take too small of a bite on the tissue, that bite may just pull through. So how are you going about? Because I saw a video out of Hopkins where there was an automation of some of the movements, and it caused some concern by some of our colleagues that the surgeon may become obsolete. But I jokingly said that it would be really great to have that type of technology, because we could become radiation oncologists almost, where we could plan out the operation and sit back and relax and have some of the mundane components of the operation done automatically by the robotic system. But if you can comment on how those two metrics could be put together for a seamless task.
Yeah, I think it's a great question. First, when the data is collected, we collect it in a synchronized manner. So an example could be the force data. So you're able to see spikes in force alongside a video and navigate across the two data streams as needed. When you create a summary statistic, such as an objective metric, exclusively from kinematic data, without detection from video, you may not be able to understand clinical context. And so we tend to think of those together, where the clinical context could be tagged. It could be learned from video and kinematic data. It could be tagged from the surgeon themselves or surgeons themselves. But there are classes of problems where kinematic data alone seems sufficient, and then there might be things that video alone seem sufficient, and then the fusion of the two allows for a more complete picture. Dr. Andrew Hung has done some fantastic work in gesture analysis within urology, and has extended that systematically, looking at kinematic data, looking at visual data, and now trying to drive behavioral change in trainees to learn things like needle throwing during anastomosis more effectively. So definitely an area of research, but hopefully helping to address your question partially.
Yeah, no, thanks. That's fantastic. And any predictions in terms of when complete automation might happen?
I think that's a research project at this point in time. I think the work from Hopkins and others, Berkeley and UCSD is incredibly impressive, and on the shoulders of some of the newer methods that are coming out with multimodal models and language models and things like this. But I think right now, describing and understanding what makes good surgery and having surgeon be central is critical, and then ultimately augmenting ways, whether it be through advanced imaging techniques that you saw in terms of new molecules, or in terms of more intelligence that augments a surgeon, will be what we see first.
Great, thank you. So there are a couple of questions on the chat. Dr. Sukandi asked, where is the ICG injected exactly? Seems like it's a bit complicated injection. Can it just be injected in the peritumoral area, similar to how we would do in cases of breast cancer, such as 3, 6, 9, 12 o'clock? I think he's asking, do you really need to pick out all those portal pedicles individually in order to do the injection, which, I mean, it was great, but it does seem somewhat challenging to do. Xiaoyi?
Yes, that's a really good question. So I showed the different usage of the ICG because first we use the ICG to tattoo the portal vein territory. So we inject the ICG into the portal vein directly. Of course, it's just a small amount ICG. And the second case, I show the sentinel lymph node or regional lymph node mapping technique. It's different from the breast cancer because in the breast cancer or gastric cancer, you can inject the ICG around the tumor, then you can get the spread of the ICG through the lymphatic channel. I tried this technique in the liver, but it doesn't work. So we inject into the glycerol particle in the liver, not injected into the portal vein or hepatic artery, just inject the ICG into the space between the artery or portal vein. So it's a little bit different from the other cancers. So I think this is mostly a difficult part because the puncture is quite difficult. The area is very narrow. You don't to inject into the portal vein or hepatic artery. So first you have to check or find the good place or site to inject by the BR ultrasound.
I see. So that sort of answers the question that I had, which was whether you can follow the ICG injection, because I thought it was being injected directly into the portal branch. And once you've identified that segment or subsegment by ICG, whether you can follow that up with embolic injection of embolic material to aid in the hemostasis. There's another question by Dr. Ganem. Are these intra-op ultrasound drop-in probes with portal vein direct injection available robotically?
Well, it's a question for me or for the intuitive engineering.
Maybe
I'm
a
not sure.
question for you and then a nudge to Tony.
Also, I think we can use the same laparoscopic probe during the robotic approach. Actually, I do like this. I ask my assistants use the laparoscopic BR ultrasound, which is a BK from the DMARC or something place. And also we have the robotic ultrasound probe, but those probe without the guide hole. So you have to do like freehand puncture technique. It's a little bit difficult than the BR ultrasound with the guide hole. So we also developed, I not mentioned, we also developed the navigation system, which is an electric magic puncture navigation system. So if this works good, we can integrate with the robotic probe. It's more easy to do the puncture with the navigation system.
Mm-hmm.
And it also works for the ablation. I think the puncture is also works good for the ablation.
Mm-hmm. Yeah, I've seen that before. The guide hole that is present on the laparoscopic probe, what is the depth by which can that be controlled? Where the tip of the whether it's an ablation device or the injection needle in this case, what is the depth where it reaches the center of the ultrasound probe?
You mean the probe I use?
Mm-hmm.
Yes, it's commercially available. It's from BK. So we call it implant technique because there is the guide hole. So when you introduce the PDCD needle, you can see the tip of the PDCD needle, and actually you try to keep the tip in the plant. I mean the BR ultrasound image plant. So you can always see the tip and your puncture way. And sometimes it will go a little bit away, but you have to control it and move a little bit your probe. You can move to the right or left and also control the movement of the needle. And also, I think it's good for robotic approach because you can use the robotic probe to control the needle movement to get the right plane in the BR ultrasound scanning plane.
Because the current drop-in ultrasound probe doesn't have a guiding system. So it may be a little bit challenging just to align the tip, especially if the target is deep. And that's what I was asking about in terms of how far is the projected location of the tip from the surface of the capsule of the liver. Any other questions from the attendees? Sorry that we can't have I didn't realize that the attendees were muted. But we have some great speakers today. If you could leave some questions on the comments, can certainly follow up even for Theodore's talk. Follow up with you and get the answers to your questions to you. Perhaps a question for you, Tony. I think we briefly discussed this previously, but what is the state of the technology in terms of predicting the next move or predicting what the best-in-class surgeons would do at a juncture where there's some difficulty being met by the surgeon, especially if they're somewhat less experienced?
So I think there's a decent amount of work and a lot of really great results around comparing kind of experts and novices or learners and more experienced surgeons using objective metrics across either a case or across activities or across gestures within a surgery. And they've led to really interesting results, which are somewhat predictable in terms of expertise, and also sometimes not exactly what you'd predict, where expertise based on case volume doesn't always map to expertise based on objective metrics or even outcomes, but highly correlated. In terms of intraoperative clinical decision support of forecasting the next move and trying to correct that next move, those are not things that are currently supported. There have been various research papers that have been published by teams attempting to do that. One area, though, that I think is interesting, one of our research collaborators is looking at it, is to be able to understand, are there signatures within surgery based on this objective metric, these objective data streams that suggest hesitation or other sorts of things that could lead and correlate to maybe indecisiveness or other decisions that could be made. So I would say right now it's a research problem, but we have really great indicators to suggest that there's signal in this data to pick up on potentially some of the workflow challenges or the efficiency challenges.
Yeah, thanks. Yeah, I think having that capability, once we have that capability, as Theodore was talking about previously, where surgeons, there's actually another question, but I'll get to it in a second. Pat, he had a paper from his group about varus needle injuries and identification of varus needle injuries. That was one of the earlier papers from the platform. And there was a significant, I think, maybe a fourfold difference in terms of recognition, or even higher recognition or remembering that there was such an injury. And I know that capacity doesn't exist currently, but given that there can be phases of the operation agnostic to the procedure that you're recording, especially on the new unit, is there a possibility to, in real time, examine if there were any injuries that were made unintentionally, of course, prior to the closing of the case?
Another great question. I think that the ability to recognize what happens and what was done to particular structures during surgery falls within the category of intraoperative clinical decision support. And that's definitely an area that we are leaning in on and exploring, as well as other companies, and using some of the things we're finding around surgery to inform it. I think to answer your question, maybe more kind of academically, without advanced imaging modalities that can see through tissue, right? You need to be able to pick it up from either a proxy of a kinematic signature or from the video itself, and potentially remember or signal risk associated with it. So I would say that there's definitely an opportunity to indicate suggested opportunities for review, but it's not something that is part of our platform right now.
Yeah, thanks. So Dr. Silla asked this question. It would probably be more useful to understand operator response to unexpected findings / complications that try to distinguish between masters, experts, when it comes to just accomplishing a safe procedure. Any research in that area?
So I think it's a great question. I hope I interpret it correctly. So just being able to do group comparisons between different segments of a surgeon population, from someone learning to someone who is mastering new techniques or mastering surgery, is just one class of problems there. And doing that through objective metrics clearly is helpful and potentially actionable. But being able to understand, does someone do something differently based on an event that occurs during surgery, is what I'm interpreting the chat to be. And there's been some pretty interesting work done examining either anomalies or outliers, as well as workflow. And so if you look at some work that's been in the thoracic space and a few others, is how do you make choices on what particular surgical activities you move to and move from. So if you imagine I have 12 steps of a lobectomy, and I bounce back and forth between those steps at different moments in time, we classify that as entropy. And you can see significant differences based on potential complexities or other things that are happening during surgery. However, I think that research is still early. It's been replicated in colorectal for LAR with some pretty interesting results in terms of just workflow analysis, not yet in terms of decision making. I think it's a massively big opportunity for future research. Dr. Silla.
Great, thank you. And maybe one question for you, Xiaoying. I saw in your paper that there were about maybe 600 or so patients that you were distinguishing microvascular invasion in. And I was just wondering, what type of, and some, one other paper, you had over 2,000 patients or specimens. And I'm just wondering, what is the exact signal that your neural network is looking for, and how many patients do you need for it to be accurate enough? I understand that it's learning and validating based on repetitive, exposure, but how many samples are necessary to get to a state where you could utilize this in clinics?
Yes, this is a really great question. We are working in this because after publish the paper, we try to do like a multi-center validation and to adjust the model. The model usually need to adjustment according to the validation. And now we get more than 2,000 cases to training. As the case accumulates, the model a little bit changes because the engineering help us to develop it. And now we try to we're trying to do the clinic evaluation, which is a pre-operative perspective. How to say the evaluation, the MVR. It's still ongoing, and I think that accuracy already achieved 30%, sorry, 70%, more than 70%. We still accumulate more case to try to training the model become more accurate. And when it achieved 80%, I think it can use to in the clinic, and also give us the information for the patient with the MVI. We need to get a wider surgical margin. And also interesting, when we do the ICG guided anatomical resection, the outcomes show it great for MVI cases, because for the MVI it's more chance to spread through the portal vein. So we use the ICG to tattoo the portal vein and then remove it. It will reduce the recurrence. The recurrence-free survival increase 15%. So I think it works great if we combine it with the AR predict the MVI, then use the ICG for those MVI positive cases. It might improve the over survival for those cases. But I think the more case is more better, because we can get more accurate of the predict.
Great, thank you. Well, it looks like there aren't any more questions from the attendees. So I want to thank you once again, Tony and Xiaoying, for making time and spending time with us and educating us about what's in the near future, maybe soon, we can apply for our patients. So thank you very much for your fantastic talks. We're looking forward to collaborating with you.
Thank you.
Thank you very much for having us.
We'll conclude this session. Thanks, Barb.
Thank you.
Thank you for the invitation. See you.